Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
The words pain science and pain education are used so frequently nowadays in professional circles that we rarely take the time to explain the difference between the two or reflect on what clinical practice was like before these advancements came into our life and what it was like for people living with pain without this knowledge. Pain science is a part of the larger field of neuroscience, which investigates nociception and the lived experience of pain. It is most often taught in university physical therapy programs, but over the years, it's begun to show up in the training of many licensed healthcare professionals. Pain education, on the other hand, is one component of an overall cognitive behavioral intervention, which teaches people how to effectively self-manage chronic pain. It focuses on the components of each individual's pain experience and how it affects their daily lives. Research shows that when people have a better understanding of how pain works in the body, it can ease fear, anxiety, and create hope. It also improves the skills of healthcare professionals so they can successfully assess, treat, and understand the lived experience of pain. Pain at times is a normal part of living. Understanding both the science of pain and how to educate people about pain alleviates suffering and improves the human experience. Today, we take the time to honor the many voices and minds of those who have advanced the field of pain science, pain education, and those who have joined me on this podcast. We begin today with Integrative Pain Science Institute instructor, Dr. Carrie Rothschild. And then, so there's a bit of a distinction between pain science and pain neuroscience education. Some overlaps, but some distinctions too. Can you tell us about the distinctions between them and then how you approach that within the context of the course you've created?
Absolutely. The course is actually called Pain Mechanisms and Treatment and Rehabilitation. So it definitely is a comprehensive look at pain from the basics of the pain neurobiology and then into how do you best assess pain and inclusion of a lot of the outcome measures that have become popular. And then we go into talking about those individual differences and pain variability that you see in different patients and different populations. We talk about the mechanism-based approach to pain management for the PT. And then we do spend quite a bit of time talking about therapeutic alliance and talking about motivational interviewing. We do some role play with those two topics. And we do talk about pain neuroscience education as an intervention or as an educational intervention. And I explain pain type of modeling, again, as a mechanism for educational intervention. And then we actually get to review some of the key concepts of the modalities course, which was taught the semester prior. And then we talk about some of the other interdisciplinary topics that are related to pain, some things that you've highlighted on your show, like sleep hygiene and nutrition and lifestyle factors. And then we talk about some of the psychological approaches that are used in pain management as well. So again, some of the things you've covered extensively on your podcast with regards to cognitive behavioral therapy and ACT and just even basic relaxation, breathing, mindfulness-based stress reduction. So they get all of this kind of in the beginning and then the very last 2 weeks. Then we talk about all those concepts in the context of some of the common pain syndromes, if you will, like fibromyalgia or chronic headaches or chronic low back pain, even moving into like chronic regional pain syndrome and osteoarthritis, rheumatoid arthritis, those kind of things. So it's definitely more, to get back to your question, definitely quite a bit more than pain neuroscience education, which really encompasses just about one module of the 10 modules that we have.
Up next is Dr. Carolyn Berryman. But what does the literature say about cognitive function as it relates to those with chronic pain?
Yeah, so that was a big part of my PhD. And we did a couple of systematic reviews, which were quite large, because a lot of people have investigated cognitive function and its effect on pain. And the literature before we did this systematic review was actually quite disparate. There are some people that would say that it had an effect and interfered, that pain actually interfered with your cognitive function. Other people might say not. And part of the reason that that happened was that when we were looking at the 24 studies for working memory deficits in people with chronic pain, we found that they tested tested working memory in at least 24 different ways. And so people have decided to make their own or design their own ways of testing these kind of cognitive functions. And part of that is that ill definition or ill-defined concept that cognitive function is. Nonetheless, we found over the literature that, in fact, working memory is poorer in general in people with chronic pain states, and we took it just as a very broad definition of chronic pain, meaning that they probably have a little bit more difficulty dealing with that sort of interaction with the environment and the day-to-day activities of daily living, calculating change, all the sorts of things that are sort of an ongoing concentration and mental capacity, and also set shifting. And set shifting is otherwise known as mental flexibility. So that ability to change your idea, change your concept of how you see a particular problem.
Professor Lorimer Moseley, because we're starting to talk about the interaction between the nervous system and the immune system and this balance between a pro-inflammatory state and an anti-inflammatory state, which all of us are constantly going through. How does Explain Pain, the psychoeducational intervention, influence this balance in our body?
Well, lovely question. So the precise answer to that is we don't know. However, if we were to predict on the basis of what we do know, what would happen, there are several things that are relevant. For example, learning new data in animal studies is anti-inflammatory. The spatial data associated with learning also maintains a sustained anti-inflammatory effect. So in the animal model, if the animal learns something cool in a certain location in the maze, that location in the maze potentially becomes an anti-inflammatory location. Now, I imagine that's about cues of different sorts, and even that is an extrapolation of data. So to extrapolate it to humans it's a big extrapolation. But if I was to talk more, maybe ideologically, if that makes sense, theoro-ideologically, another term I made up just then, I would say that I think there's very good evidence to say that explaining pain is anti-threat. Could argue that anti-threat is anti-inflammatory. Explaining pain I would describe as a big sim in the language of the protectometer, or you guys might say the protectometer. A big hit of safety cues and understanding and appreciating, I can do something about this and have some skills to do it. And it makes sense why my pain's worse in this place or with these people or with these different cues. Then anything that is anti-threat is not just about feelings like pain. It's about all of our protective mechanisms. And one of our protective strategies is to become inflamed. So, to go back to the precise answer, we don't know. The predictions are, as I've just said, it should be anti-inflammatory.
Dr. Greg Lehman, you also talk about being robust often, that one of your goals is to help people to reconfront their thoughts and emotions or their beliefs about how they can be more robust in their life and in their health. Can you talk about that a little bit?
Yeah, robustness to me is just tolerance. It's meaning that you're going to have things that try to knock you down and you can cope with them. And when you have persistent pain and when you get out of that and you're recovered, you're still going to have flare-ups. Right? You can, the definition of stability means there's a perturbation, you get knocked, and you should come back to your original resting state. Robustness means that you can tolerate more and more perturbations to your life and come back to that resting state. That's a stable system. And a more robust system means it can tolerate more stressors. That's what we're trying to build. And I think it might be a synonym for, that's the idea of resiliency. Mm-hmm. The robustness and resiliency, because we can't avoid all of the stressors in our life. That's what we do when something's fragile. We put the stamp on the outside of the box, fragile, handle with care. And instead we should be saying, you're not fragile. You don't have to handle with care. You need to stress it to make it more robust and adaptable and tolerant. That's the cool thing. We're not eggs. I don't think an eggshell responds to load. That you don't want to drop.
Pain researcher, Dr. Jeffrey Mogul. Can you tell us, everyone is always asked the question, who is more sensitive to pain or who feels, quote unquote, feels pain more intensely, men or women? Can you talk about that debate a little bit?
Yeah. So first, I'd like to point out that it's a pretty odd question, right? Because most scientific questions, you go to people on the street and you say, what is your opinion on this scientific question? And they look at you like you're an idiot and say, how would I know I'm not a scientist? But if you ask them that question, everyone will guess. They will all guess 100%. And mostly they guess wrong. right? So the idea that people seem to have in their mind is because women undergo labor, they must be more tolerant of pain, less sensitive to pain. So here's what we know. We know that women are greatly overrepresented as pain patients. Okay, so if you go and you talk to pain doctors that have specialty practices in pain and you ask them what percentage of your patients are women, you'll get answers that are around 70%. Okay, so about 70% of the pain patients are women. Now that could mean that women are more sensitive to pain, but there are other possible explanations there, right? It's possible that women are just more likely to go to the doctor. And of course, you can't become a patient unless you go to the doctor. So maybe women go to the doctor more than men. And of course they do, right? I mean, this is well known. And it's not so much that women go to the doctor more than men, it's that men refuse to go to the doctor, right? So a better way of answering the question is not by looking how many patients there are, but by doing broad surveys.
Dr. Tin Solomons, can you explain what the pain neuromatrix is and what the best evidence of it really, how it can inform a clinician's practice?
Yeah, no, that's a terrific
controversy around that.
Yeah, it's a terrific question. And it's one that I've been spending a lot of time on because obviously if you're like me and you do neuroimaging and you're interested in the brain and you believe that the brain plays a very fundamental role in pain, the first thing you're looking for is can we actually recognize pain when we see it in the brain? And I think what has really driven a lot of this is that we struggle with whether we can trust subjective reports. Because sometimes people are looking for medications or, they may have many reasons not to be forthright with their pain ratings. So, everyone is always saying, well, I wish we had an objective measure. And so we went about sort of 10, 15 years running these pain studies and we got what we called the pain matrix. It was a pattern of activation that no matter what pain imaging study you run, you see this same pattern of activation. Not to bore your listeners with long lists of brain regions, but regions like the anterior cingulate cortex, the insula, the thalamus. If you don't see these regions in a pain imaging study, you're probably doing something wrong. So people started to think, well, maybe this is the objective marker we've been looking for. Maybe the brain is going to we'll have one of these things in every doctor's office, and companies started to offer legal, we can do this in legal settings. What we've actually found, as much as I'd like to say that neuroimaging has solved every problem, because it would certainly benefit my work in terms of funding, but what we've actually found is what we thought was the pain matrix, or maybe a specific signature for pain, turned out to not be as specific as we thought.
Physiotherapist and pain researcher, Dr. David Butler. What are the key principles that practitioners need to be successful for explaining pain to patients?
Yeah, thanks. First of all, that's something my colleague Lorimer Mosley, some of your listeners would have surely heard of. We worked together a lot, and when we wrote Explain Pain, we were essentially telling the story of the neuroscience in a language patients and therapists and health professionals would get. And then we realized a little bit later that we needed to do more on how to translate that information over, which is essentially conceptual change theory. How do we change concepts in our patients as well? So that's merging the education element in with the neuroscience. And there's a few things there to be good at it. I first of all think you've got to have a biopsychosocial approach, right? That's the first thing, the nice wide biopsychosocial approach. But there's also competencies that health professionals need. I think you need to be, first of all, biologically literate. And biologically literate these days means, first of all, an understanding that neuroscience is changing at an incredible rate. Our old systems we learned about nociceptors and stuff is changing. We have to be neuroimmunologists. I think if we don't take on the immunology and realize that at least 50 to 80% of the brain cells have got an immune function, that we're really sort of missing something. The glial cells have an immune function and are critical in learning and health and sensitivity.
Dr. Cormac Ryan, what's nice about your research is it begins to culminate with some principles that you share that can help practitioners with their application of PNA and potentially make it more effective for obviously the clinician and the patient. Can you share a couple of those principles with the practitioners who are listening?
Absolutely. I think I go back to, I think mixed methods, systematic reviews are the future. I think they're extremely powerful because they don't just focus on the numbers. They focus on how to do the work well. from the perspective of the clinician and of the patient. One of the key things which seemed to be important for the patient was the ability to be able to tell their story. This idea of just kind of going in and delivering the education in a very bland way and leaving doesn't seem to be the optimal way of delivering it. Sitting down with the patient, asking them to tell you their story and giving them time to voice their concerns, I think is actually an integral part of PNE. It shouldn't just be a one-way conversation. In doing that, in allowing them to tell their story, patients often identify inconsistencies in their own stories, which begin to harpoon the medical model and the biomechanical model in their own mind, which can help you when you're thinking about delivering pain neuroscience education to them. It's almost, I think it should be a prerequisite to delivering PNE. I think if you're delivering it in a cold, bland way without listening to the patient's story, you're going to have less of an effect. So I would say that's probably number one. And also, in terms of that, I think probably the key thing of all of our work has been around the issue of relevance, making the education relevant to the patient. And having listened to their story first will allow you or help you when you're delivering the education to make bespoke to that individual.
Pain researcher Peter Stilwell, about this, one of the things that I try to talk to practitioners about is kind of just maintaining a sense of kind of this flexible out of the box thinking. Because if you box yourself into any one theory, or if you box yourself into any one treatment approach, especially, I think is most problematic. But maintaining this flexibility to think about the patient and what they're experiencing and how that's going to influence your evaluation, your treatment, your plan of care, your interaction with the patient. How does this model help with that flexible out of the box thinking that people have maybe fallen into with regard to that bio, psycho, social silos?
Yeah, at least Sannika Dehaan's work really emphasizes that flexibility. So she uses examples of these network models, and she shows all the kind of intertwined factors and how they change over time and how that shapes that individual's experience. And I think that's important because that changes over time based on the person. Their body might change, the environment might change. And so treatments maybe that worked in the past might not work in the future. So we have to kind of be constantly attuned to that individual, their current perspectives and how things might be changing. So yeah, working with a philosopher now out of Germany to try to explore some of these ideas in relation to pain. And yeah, excited. I'm slowly learning and struggling. And I have a crisis at least once a week where I'm just where am I going with this? Because I get excited about all this different literature. And I don't know, at least some people might find it valuable. So that might be worthwhile. Yeah.
Neuroscientist and neuropsychologist Lisa Feldman Barrett. If you look at the International Association for the Study of Pain's definition of pain, it's that it's both a physical as well as an emotional experience, which is why I, of course, wanted to have you on to talk about emotions. And you touched on it just briefly there. In your theories and perspectives and constructs that you've helped build out with regard to emotion is that emotion is a perception. And that perception happens kind of ahead of time, even before it comes to our consciousness.
There are so many things that are fascinating about how brains work. And I was just telling my husband this morning, we were talking about prediction in particular, and I was saying, if I wasn't a neuroscientist and I didn't see the evidence with my own eyes, I'm really not sure I'd believe it actually, because it sounds so preposterous. But yes, the way to think about it is that, here's an example, I think, which maybe illustrates it nicely. I use this in 7.5 lessons about the brain. When we're thirsty and we drink a glass of water or whatever, a glass of some beverage, some cool, refreshing beverage, we drink the whole thing. We're not thirsty anymore. But it takes 20 minutes for the liquid that you've imbibed to reach your bloodstream and change the osmolarity of your bloodstream to tell your brain that there's more hydration there. So 20 minutes earlier than the biological signal is there, you stop feeling thirsty. Why is that? And the answer is the same answer that I would give if you asked me, what is so interesting about baseball? How does a batter swing a bat at a ball that he can't see, where it's going to be, but he's swinging, where it's going to be in a moment from now? And the answer in both cases is your brain's predicting. For your whole life, you've had many, many, many occasions where you've drunk liquid and then at some point later you stop feeling thirsty. And so your brain basically is preparing your experience before the sense data actually arrive. Now, in the case of drinking water, it's 20 minutes. That's a long time. But in the case of most things, it's very, very quick. There's an example that I use when I'm demonstrating how the brain predicts, and I get people to imagine an apple. And I would say, I don't know, 70 or 80% of the time, people would say, I'm salivating. And I'm like, yeah, you're salivating because I just got you to predict that you were going to eat an apple. I mean, you don't really believe that you're going to eat an apple, but for your brain to even understand what an apple is, it has to engage in the same neural pattern. And part of that pattern is preparing you to digest it. That's why you salivate in advance of eating a food. And in fact, Ivan Pavlov won a Nobel Prize for this at the turn of the century. His explanation for this phenomenon was completely wrong. And it was wrong for about 100 years, actually. But in fact, that's what's happening. Your brain is a prediction organ. It's predicting on the basis of how things are right now. If we were to stop time, your brain has some representation of what's going on inside your body and what's going on outside in the world. And your brain is predicting on the basis of past experience what is going to happen next. And the prediction is your brain changing the firing of its own neurons to prepare to receive the sense data and to act on it. So your brain starts to prepare your experience and your actions before it makes itself aware of that preparation.
Physical therapist, Major Timothy Benedict. First, tell us, is there some research supporting PNE, pain neuroscience education for PTSD? And then tell us about your work specifically.
Yeah, so of course I had this idea that it just made perfect sense to me. I have a link between chronic pain and PTSD. So just to get a diagnosis of PTSD, there's a few clusters. So number one, after you've had a trauma, you start to re-experience this trauma. Okay, number two, you're hypervigilant. And number three, you avoid things that remind you of that trauma. And then it's very common that you have comorbid negative cognitions like depression, feelings of remorse, guilt. And so when I look at that cluster there, we see a lot of things in chronic pain as well. So we know people in chronic pain, they avoid, they re-experience spontaneous pain even after tissue should have healed. They can be hypervigilant, have central sensitization. So definitely to me, it seemed like there was a pretty close conceptual link between those two issues. And so I wanted to first make sure that as I talk about the neuroscience of stress and pain, that veterans, that individuals who have PTSD would be able to understand it, would be able to comprehend it. And so there's lots of other studies that have looked at the same type of issue. Hey, let's make sure that the end user, the patient, can understand pain neuroscience. And of course, just like what Mosley has found, just like other practitioners have found, patients do a much better job than what we as clinicians typically give them credit for. And so the first aim was making sure that these veterans could understand it, and then that using the military stories, like when I talk about Pearl Harbor, would connect with these veterans and would actually help them understand what's going on with PTSD and with stress. That was the main aim, first of all, before going out and launching it in a clinical trial. Can these veterans understand it? Does it connect with them? And that's what the first study, just pilot study with the sample of several individuals, both with and without PTSD, and found that they had really good comprehension equal to a medical expert panel once we controlled for years of education. And so we met our first goals of making sure that our end user would be able to comprehend these materials.
Physical therapist and pain researcher, Adrian Lowe. Why is it still considered a radical idea that physical therapists can use the mind and cognitive behavioral interventions in practice to help people?
Yeah, that's a good question. I mean, there's multiple answers. It's the models we follow. It's the legacy of Rene Descartes. I think the biggest thing is when I hear from therapists that, I don't do that, or I'm not going to go that way, I start laughing because you're already doing it. You don't know you're doing it. I've made many people better by what I tell them, but not by the technique I did. Those kind of things. I think I don't push them. I leave them be. That's fine. Do your thing. We'll all get there. But I think the reluctance is the models. We need to significantly update the models we're teaching and understanding. Then there's a stigma, right? Oh, it's in my head. Oh, you think it's not real. all pain is real. I mean, I'm a neuroscientist. We scan brains, and I'm telling you, we've never scanned a brain and let's call it fake pain. All pain's real. And a message, if your patients are listening, if a provider ever makes you feel like you don't believe you, then fire them and go find somebody else, because your pain is real. But it's leftovers from the models we were taught for years, very peripheralistic, leftover from years ago. But for the clinicians that think they're not doing it, I have a message for you. You're doing it. You just don't know you're doing it. So that's the fun part, actually.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.